We are starting with the first session. Professor Trendafilova is the moderator, so it's my pleasure to give the floor to Professor Trendafilova for the first session regarding the vascular access in endovascular interventions. Didi.
Dear Professor Petrov, dear Professor Velchev, dear colleagues, it is my pleasure to take part in BEC 2021, and I'd like to thank the organizing committee for the invitation. The first session is vascular session. So the first lecture is access for Tavi. So I'm going to talk about Tavi access. So, unde se vижда? Indication for valve replacement in aortic stenosis are symptomatic severe aortic stenosis, which include symptoms, dyspnea, angina or syncope, and echo evidence of severe aortic stenosis, and asymptomatic aortic stenosis with low ejection fraction below 50%, undergoing another cardiac surgery operation, and very severe aortic stenosis. Revolution begins in 2002 when Dr. Alan Cribier performed the first transcatheter implantation in a patient with end-stage heart failure. During the last decade, we have transcatheter aortic valve implantation has revolutionized the treatment of symptomatic severe aortic stenosis. After well-designed randomized clinical trials, Tavi is considered the best option for treating patients with symptomatic severe aortic stenosis who are inoperable and high or intermediate operative risk of death. As a result, international guidelines have recommended Tavi in inoperable and high-risk patients class 1 and intermediate-risk patients class 2A. Since the start for Tavi now, many aspects have changed, both in the diagnostic procedure as well as the performance of Tavi procedure itself. While Tavi was only a treatment option for extreme and high surgical risk patients in the early days, the indication for Tavi has now expanded to low-risk patients. This evolution has gone hand in hand with the standardization and simplification of the entire Tavi workflow. During the last decade, we have continued the rapid evolution of Tavi devices, procedural techniques and populations, increased minimalist approach with conscious sedations and early discharge. General anesthesia and TE guidance is recommended still in high-risk anatomy, heart team approach, and we still use risk score system like STS and EuroScore. Tavi is technically achievable in almost all aortic stenotic patients. A wide range of specific anatomic evaluations, however, must be considered when referring the appropriate candidates for Tavi procedure. Large sheets and catheters used in these interventions increase the risk of vascular complications, which have established as the main limiting factor of the technique. They can increase early and late mortality, so it is essential to choose an appropriate approach. Whilst initial Tavi experiences were limited to a small number of devices, now we have a wide selection available. The principal advantages of the newer devices include the requirement for small delivery sheets, the ability to reposition or recapture, and specific designs to reduce the frequency and severity of residual aortic regurgitation. What makes a Tavi case complex? The first reason is access. That includes poor iliofemoral access, marked iliac or aortic tortuosity or concomitant aneurysmal disease, limited alternative access options like porcelain aorta, severe lung disease, small axillary arteries, patient limb graft. The second reason is root or annular anatomy, which includes small sinuses or valsava short coronary aids, heavy calcified left ventricle outflow tract, vertical annulus, large annulus, bicuspid aortic valve. The third reason is ventricle function or concomitant cardiac pathology. These are patients with low ejection fraction, no revascularized coronary artery disease, poor right ventricle function, or prior left ventricle assist device, and the last reason is patient comorbid condition. Of course, there are multiple points to do the procedure, but the most preferred approach remains transfemoral approach. In the updated guidelines, it is now clearly stated that multi-slice computer tomography is the preferred imaging tool to assess the anatomy and dimensions of the aortic root, size and shape of the aortic valve annulus, its distance to the coronary ostia, the distribution of calcifications, and the number of aortic valve cusps. It is essential to evaluate the feasibility of the various access routes, as this provides information on minimal luminal diameters, atherosclerotic plaque burden, the presence of aneurysm, thrombi, etc. That's why proper patient selection is key. Evaluation of the peripheral vascular anatomy is important to the success of the case. Most vascular complications are due to improper vascular screening. If the peripheral vasculature is suitable, then the transfemoral vascular approach has a number of advantages, including shorter procedure time, faster patient recovery, and superior outcomes when compared to the transapical approach, and is now the default access site. Furthermore, whilst initial Tavi devices required the use of large delivery sheets that required surgical cut-down, new, smaller sheets have now enabled the procedure to become truly percutaneous. Other access sites should be considered when the transfemoral route is not thought to be suitable. Current consensus and expertise strongly favor the femoral artery as the preferred and the most widespread access site for Tavi. Both surgical cut-down or percutaneous approaches are feasible to enter the femoral artery. The choice of device is currently dependent on patient-specific anatomy, operator preference, and center expertise. Diagnostic modality for access evaluation includes invasive angiography, multi-slice computer tomography, and iliofemoral intravascular ultrasound. We must assess three critical factors: iliofemoral arteries, like diameters, calcification, like extent and location, and tortuosity. We need to have CT images to assess the size and quality of the peripheral arteries necessary to allow access. The quality of the examination is important in order to obtain good reconstruction and precise measurement. Another way, we need to evaluate calcification as a grade of calcification and extent of calcification. Another way to evaluation of calcification is with use intravascular guidance. 3D reconstructions particularly useful for assessment of tortuosity. Vessels which are tortuous but not heavily calcified often can be straightened with stiffer wires. Vessels which are tortuous and heavily calcified are not favorable for transfemoral Tavi approach. And this is one of our cases. This is a 76-year-old male. Here you can see the CT images for peripheral arteries. As you see, this patient had peripheral arteries with good diameter, but quite tortuous and with moderate calcification. This is a measurement of aortic root. According to the measurement, you can see that this patient had bicuspid aortic pathology, functionally bicuspid aortic valve pathology. In this patient, we discussed to use the Evolutar 29 with transfemoral approach. In this patient, we used Lunderquist wire and managed to do implantation successfully in accurate position. In the second picture, you can see the final result. This is result is after balloon angioplasty. You can see that we don't have aortic regurgitation. This is another patient where Lunderquist wire didn't help us. As you see, this patient was with severe calcification of the aortic root and severe tortuosity of peripheral arteries, in both peripheral arteries. The valve, in this patient, we used the Edwards Sapien valve 329 according to the measurements. And after several unsuccessful attempts to cross the valve with the system, we lost wire position. This is a very complicated situation in this device because Sapien valve as a device doesn't allow second use. What we did in these patients with contralateral femoral approach, we managed to cross the valve with the wire, change it with T41, second Lunderquist, predilate, and finally we managed to cross the valve with the whole system and to do accurate implantation. The third picture is the final result. Alternative access, transapical approach. This approach requires a small left thoracotomy and direct puncture of the left ventricle apex and avoids the requirement for large catheters to be advanced through the iliofemoral system and aortic arch. The main disadvantage is the requirement for general anesthesia, a greater degree of myocardial injury, and longer recovery times. Complications during transapical procedure might be related to left ventricle pricking, bleeding, hemodynamic or respiratory compromise, and thoracotomy pain. This technique is particularly recommended in cases with high risk of stroke or other embolic events, such as patients with advanced peripheral artery disease or severely calcified thoracic aorta. And this is our patients with transapical approach. In the first picture, you can see the valve positioning of the valve and the second final result. This is another outpatient. This is a 59 years old lady after 2 surgical procedures, and because after ischemic stroke with right side hemiparesis, because of the severe degeneration of prosthetic valve, we decided to do valve-in-valve procedure by transapical approach. Here you can see that CT and T pictures confirmed left atrium thrombosis. In these patients, we used, of course, general anesthesia, transapical approach, T guidance, and protection device, and managed to do the implantations with a good final result. In the third picture, you can see the thrombus particulars removed from the filter wire. Transaortic access is an alternative Tavi approach, achievable through a mini sternotomy or a right thoracotomy, but always allowing exposure of the proximal ascending aorta. And here you can see one of our patients with transaortic approach. Other vascular access options with demonstrated clinical efficacy in the settings of Tavi include the transsubclavian, transaxillary, and transcaval approaches for patients with anatomy that is unsuitable for the more traditional techniques. The transaxillary or subclavian access route is safe and represents an increasingly accepted option in Tavi candidates, with contraindication to both a transfemoral and transapical approaches. Right subclavian artery can be used, but device positioning becomes technically difficult when the plane of the valve and the horizontal plane form an angle more than 30 degrees. If the left subclavian artery has been previously used in a coronary artery graft, left internal mammary artery flow might be impaired. In these settings, sheaths insertion and device placement must be carefully done by fluoroscopic guidance. This is one of our cases. Here you can see the peripheral CT images. This patient was after severe peripheral, this patient is with severe peripheral disease after orthofemoral bypass. In this patient, we decided to use left subclavian approach. This is the implantation. You can see in the first picture, release the valve, and the second picture, final results. This picture showed assessment of vessel integrity. Transcarotid approach via the common carotid artery represents a direct route of the aortic valve that shortens the distance from the arterial entry site to the aortic root. The transcaval aortic access is relatively new technique intended for Tavi in candidates not suitable for the other arterial approaches. In the transcaval approach, the delivery system is inserted through in the femoral vein and crossed to the arterial system by creating an aortocaval fistula, which is closed with an Amplatzer device after the valve is deployed. Our center doesn't have any experience with transcaval approach, but we have some experience with transvenous approach in valve-in-valve procedure in tricuspid position. And this is our first patient. This was one lady with severe degeneration of biological valve in tricuspid position. We started to do the procedure through the femoral vein, but because of the tortuosity and large right cavities, we didn't find good position of stiff or wide. That's why we changed the approach and managed to do the procedure through the jugular vein. This is our patients where we did the implantation successfully through the transfemoral vein. In conclusion, transcatheter aortic valve implantation has evolved into a safe and effective procedure to treat symptomatic patients with predictable and reproducible results. Rates of important complications such as vascular complications, strokes, and paravalvular leaks are lower than ever because of improved patient selection, systematic use of multi-detector computer tomography, increasing operator experience, and device innovation. Accumulating data suggests that transfemoral Tavi with newer generation transcatheter heart valve and delivery system is superior to conventional surgical aortic valve replacement among intermediate and high-risk patients with severe symptomatic aortic stenosis with regard to all-cause mortality and stroke. The safety and efficacy of Tavi procedures are directly related to the proper imaging, which based on patient selection and procedural guidance. The Tavi procedure is 80% peripheral and 20% cardiac. Vascular complications are largely preventable. Prevention is the key. Careful case planning. Thank you for your attention. Тук не се появи дълго време, извинявам се, това презентацията, но сега е окей.
Не, всичко е наред.
Изкривих се.
Супер.
May I a few questions?
Probably a short discussion.
My first question is because you're completely right, it's 80% peripheral and 20% valvular procedure. So we will be facing more and more vascular complication probably, and we'll be dealing with more and more severe vascular disease. Do you have any experience with Shockwave technology to provide an access to the very calcified femoral vessels?
We don't have experience with Shockwave technology to do the suitable way to cross the peripheral arteries. We have some cases with interventional procedure like stenting in patients with severe stenotic lesion in the peripheral arteries in the place of the puncture.
we have some limited experience with the Shockwave to provide the route, and it was successful in several instances, exactly in patients like Professor Trendafilova showed, with huge calcification throughout the iliac and the femoral root. So in this situation, Shockwave, balloon dilation, or even stent implantation can be helpful. I can remember we had a patient after AAA, EVAR, endovascular intervention, and we successfully crossed with the Tavi system through the route of the already implanted several years ago. So different facilities are important to be on the shelf, and like Professor Trendafilova showed very well, that the team has to be multidisciplinary in order to have the success of surgical access and surgical closure. If you allow me, in this relation, it was very interesting, the case through jugular vein implantation into the degenerated tricuspid. Was the vein closed by surgical approach, or or the closure device? How did you do?
No, with compression, manual compression.
Manual compression.
Manual compression.
Great. Yeah.
Yes.
You can imagine how big was the
second
hole.
patient. So in the second patient, we used a ProGlide closure device, but in the first patient, in this lady, we used manual compression. Yes, longer, but
you're using stitch of 8.
Stitch
Just
of 8,
a simple
yeah.
stitch.
Yeah, it's also.
And usually it works. And my question would be, aren't you afraid to cross the freshly implanted stent with the valve? So I think there is some problem, and you may compress the stent or deform the stent if you have severely calcified vessels. So what do you think?
It's extremely nice question. In another institution abroad, our colleagues had prepared in advance the femoral approach with a stented before the Tavi procedure, external iliac artery, and unfortunately, with the Tavi delivery system, we pushed the stent, and the stent entered. In fact, the Tavi system entered the stent, but the stent didn't stay on place and went into the descending aorta, thoracic aorta. It was quite difficult what to do, and to be fair, the local team, instead of doing anything else, they proposed to remove the Tavi system, delivery system, back in order, and even the wire, to move back the wire, in order the stent to escape. And fortunately, it happened. The stent escaped and went down. It cannot go further up, so it went down. And after that, it was easy. After that, it was easy. And on the final step of the procedure, we restented the iliac artery with the proper stent, bigger one.
I guess it's a nice...
So it's
one comment.
it's
Maybe this procedure doesn't be one-step procedure. Maybe it is better patients with peripheral intervention, TAVI procedure to be done later, after a month or after the
two-stage approach.
Yes, two-step.
It's absolutely reasonable in such
I think it's a nice transition to our second presentation, which will be access for aortic stenting.